about the class, about what you are, you'll need.
I can't make sure the camera was up.
Yeah.
Yep, it's going.
Yeah, it's okay.
Oh, okay. Okay, so in terms of assignments, what is on that quiz tomorrow? Everybody got it?
Is there's 5. There's 5 different things.
So you have the 2 handouts. You have a nutrition review handout, and you have an exercise that's new from nutrition. Then you have a summary of lifestyle management, and you have lab medicine.
And then there's the other exercise.
What's that?
It's collected ADA.
The what?
The ADA, the collected the ADA.
Okay, but that's, yes, so that all just roll into the exercise.
Okay.
Okay, everybody clear? Bailey?
So are all of the intro to nutrition questions part of it, or, because none of them were starred, so are all of them part of it?
She emailed the ones starred, I think.
I think I did that last night.
She responded with them then with stars.
Is this part of the 6 question or not? Okay.
Look back and
Maybe
see,
I
because
just
I
did
thought I
this.
had all of them covered last night, but
I think you did.
Okay.
It
Oh,
was
yeah,
late.
I see it, sorry.
okay.
It's
Any questions about assessment in general? Any worries or concerns? You feel like you can do it? I know you can do it. You can do it. It's a step up, because when you leave out of here, it's another huge step up. So these are all ramping up to capstone and then out the door successfully. You can do it. You know, it's a compressed year. It is a very, very compressed year. So that's what you signed up for. Okay. All right. Doesn't mean it makes it any easier, even though you knew that that's what you were wanting. Okay. All right. Anything else from yesterday? All right. So this morning we're going to talk about the pathogens of diabetes. So let's kind of think back about yesterday. So we talked a lot about insulin and where it came from. So where's insulin produced? Pancreas, and what cells in particular? Beta cells, and they are part of a clump of endocrine cells called what? Islets of Langerhans. That's how they're identified. Okay. Insulin's main stimulus for being secreted is what? Glucose. Okay. Insulin is, once it's produced in the cell, it is stored as what? Proinsulin. When it is secreted as what? It's cleaved, and we call those two things what? Insulin and C-peptide, and they are secreted in equal molar amount. So the same thing. So if we measure C-peptide, it is an indirect measurement of insulin. Okay, very good. Insulin's target organs are what? Liver, muscle, adipose tissue. Okay. When insulin is active in the liver, what happens?
Turns off.
Turns off glucose production. Okay, so it suppresses hepatic glucose output. What else does it do? It increases glycogen production. So glucose that's coming is taken up and stored away as glycogen. Okay. In the muscle cells, what happens in the presence of insulin? What happens to glucose? Uptake. What happens to amino acids? Uptake and protein synthesis can happen. Okay. What happens in fat in the presence of insulin? There's uptake of glucose and storage eventually is what? Triglycerides. Where are the two organs that glycogen is stored? Liver, muscle. Which of those adds to the blood sugar and maintains it in fasting state? Liver. Can we get the glycogen out of muscle? No, only muscle can use that. Okay. Is the brain a insulin sensitive or a non-insulin sensitive organ? Non. Does not depend on insulin. So it just depends on the steady flow of glucose. That becomes really important because when we give people exogenous insulin or drugs that increase insulin production, and we drive their blood sugar too low, their brain cannot get enough insulin, and so the symptoms will show up. Okay? So we call it neuroglycopenia. So if sugars get around 40 or below, people will start to have symptoms of low blood sugar. So it's one of the things you can look for. Or the patient usually at that point can't realize it, but the people around them usually do. Steel magnolias, Julia Roberts, classic, moderate. She was in the 40s. She couldn't tell them. She knew something was wrong, but she could not communicate that. That was probably a good representation of a blood sugar around 40. Okay. Let's see. Insulin is an anabolic or a catabolic? Anabolic. Okay. The 4 counter-regulatory hormones are what? Glucagon, cortisol, growth hormone, norepinephrine. Epinephrine, sorry. In a fasting state, the predominant hormone is glucagon. Insulin and glucagon are like two kids on a teeter-totter, and when one's up, the other one's down. So in the fed state, the predominant hormone is insulin. Those are the things you should know off the top of your head. Okay. All right. So let's talk about what goes awry. So if you know what insulin does, then you can predict what will happen when insulin is not there. Diabetes is a continuum, it's a spectrum of relatively normal to absolutely abnormal. Okay, so the worst case scenario is what we see in type 1s. No insulin is made. Medical emergency, the person will eventually die, not right away sometimes, but in a few months or a year or so, they'll die if it's not corrected. So that we'll talk about tomorrow, or we'll talk about on Thursday. The other is a relative lack of insulin that occurs with type 2s. So type 2s have two things. They have a relative insulin lack. They may put out enough, but it doesn't keep their blood sugar under control. Okay? In normal blood sugar, normal fasting blood sugar is what? 70 to 99. Blood sugar after a meal does not usually rise above 140 in a person. And it may not even rise above 120 in somebody who's really, like you all, young. If you're thinner and you're active, you probably don't get above 120. Okay. So in type 2, there's a relative insulin lack. Even though they may be putting out tons of insulin, their blood sugars don't stay normal. So that's called a relative insulin deficiency. But they have another thing that goes on, is that the tissues will not respond to the insulin that they produce. We call that resistance. So there's insulin resistance, and then there's insulin deficiency. So we're going to talk about that today and how that unfolds. The problem with type 2s is that it's insidious. It usually, by the time people are diagnosed, they have had the disease about 10 years. Sometimes people present with complications, and then somebody goes back and looks and goes, what's your blood sugar? Okay. And there's handouts there. With type 1, it's more dramatic because it is so significant. And the symptoms are usually enough that people seek help, usually. So there's a vast difference. In the end, when you get to hyperglycemia, it doesn't matter because what happens from there on usually is the same. So we'll talk about those differences as we go forward. So today we're going to talk about type 2s. So on page 2, that consequence of insulin lack In some patients with type 2, you will never see these show up. They're there, but they may be so subtle that, and they occur over such a long period of time that the patient may not complain of them. They usually will complain to you of tiredness. Fatigue would be a comment. Or or you ask them, how's your weight been? I see you've lost 10 pounds since we saw you last year. Yep. What are you doing? Nothing. Never. If anybody ever tells you that they are not doing anything to try to lose weight and they're losing weight and they're diabetic, the first thing I'm looking at is, what are your blood sugars? Okay. All right. So these are the more significant, and they are more subtle in the type 2. But let's talk about them. Oh, I posted the wrong, I'll post an earlier version, sorry about that. Okay, let's walk through this first, then we'll look at that. Why didn't it show up? So, consequence of an insulin lack. So in insulin deficiency, you go into a catabolic state to some degree. Type 1 is the most significant, where there's big breakdowns of tissue. So in the liver, glycogenolysis takes place to release glucose into the blood. There's no information back to the liver that says there's enough glucose in the blood. So when we talked about insulin release, we talked about it in 2 phases. We talked about the first phase of insulin is its target is what? Liver. And what does it do? Say it again louder.
The liver
Stops, it changes the course of the machinery. So it stops, it tells the liver stop putting out glucose into the bloodstream and take it up and put it away as glycogen. If there is no signal, the liver will just continue to put sugar or glucose into the bloodstream. So glycogenolysis, catabolic activity, takes place to put sugar into the system. Amino acids are released from the muscle. They do that all the time, but they will start releasing more. Now, why is that significant? What happens to those amino acids? They make new glucose. Remember, we talked about 13 of the 20 are glucogenic, meaning the liver can take them and can create new glucose out of it. Lipolysis takes place, so the breakdown of fat. Buildup of fat is always under the influence of insulin. You take insulin away and the body will break those down. So what the body is sensing is there is not enough fuel, because what does insulin do when it gets out to peripheral tissue? What's its job?
Open up the gate for glucose.
It allows glucose to move from extracellular space into intracellular space. So if you don't have enough insulin, what do your cells think? We're starving, and they will tell the brain that. Okay? So all that machinery that was keeping glucose flowing into the cells no longer in place, so the body will start to tear down or allow storage of fuel, muscle, fat, liver, to release those stores of energy so that the body has something to work with. Okay? So if the cells can't get fuel, the body will work to do that. So in people who have type 1 for a period of time, they will break down lots of fat, they will lose muscle, and they will deplete their liver glycogen stores. Okay? So that's why the body's doing it, is because it perceives that the energy flow has been disrupted. And they're right, glucose won't move in, so ATP is not being produced as to the same extent. So you see why type 1s die, because they cannot get an energy source going. Their cells die, lack of energy. Glycerol is released from adipose tissue from lipolysis. What does glycerol do? Liver takes it up and does what? New glucose. Okay. Lipolysis takes place, releasing free fatty acids. Free fatty acids go to the liver and are produced what? Ketones. Ketones are, in small amounts, a secondary fuel source. The brain will use them. The problem here is that we overwhelm the system. Ketones are large organic acids. So keep that in mind. We'll talk about those later. Muscle breakdown. Decreased amino acid uptake, decreased glycogen, liver using all that amino acid substrate. Adipose tissue, we may have talked about most of this. Okay, we did. All right, let's see if we can go through this. Not on those screens at all?
There's a piece that you can plug into the computer. Did you unplug it from that one?
Did I do that? No. No, I don't know what you're talking about. Okay, let me do it with the mouse. Sorry, Kristen, I don't know. Okay, so insulin deficiency, glycogen breakdown. Can you see the mouse? Okay. And decreased glucose uptake by cells, like we just talked about. So that leads to an increase in glucose in the blood. It can't go anywhere because there's no insulin to get it into the cells of the body. Now the kidney can get rid of it, and the kidney will start getting rid of it. There is a threshold at which, if you exceed it, the kidneys can no longer absorb. So remember, glucose gets filtered very freely. It's a small molecule, freely filtered at the glomerulus, and the proximal tubule takes it all back up. So there should be 0 glucose in your urine. Okay? And that threshold is about 180 milligrams per deciliter. So high blood sugars exceeding that 180, as people get older, it gets a little bit higher, but as you're getting above 200, that glucose shows up in the urine. So it's one place you can check. You can always do it, and then you can do that in the clinic easily. Blood osmolarity goes up. What are the determinants of osmolarity? Osmolality, let's do that.
Sodium.
Osmotically active agents in the blood, so sodium. Some people put potassium, most drop it. What else? Glucose. And guess what we do? We divide it by 18. Because what's the units here? Millimoles. So this is the conversion. Remember I told you yesterday, 18 milligrams per deciliter of glucose equals 1 millimole. Okay, and then what's the other?
Albumin.
UN, urea, nitrogen. Okay, so these are the big determinants. So if you put in what's the usual sodium? I think it's 2 times the sodium. What's a usual sodium? Let's say 130, that's right in the middle. Glucose, a normal, let's say a glucose, you got a glucose now of 300. If you divide it by 18, what do you have? It's about 15, I'm eyeballing it.
16.
Okay, 16. Plus, what's a BUN if they're azotemic and their BUN's up, what would be an abnormal number? Let's put in 40. So 2 times 130 is 260, plus 16, plus 40. So 316. Anybody got an idea what a normal osmolality is of the blood? 280, around 280. Hyperosmolar, okay. So, what can the body do to get that down? Water. So you have little osmoreceptors in your hypothalamus are always watching. And so when osmolarity goes up, it says you're thirsty, you need to drink. It'll still make you thirsty, would be how people would feel. Okay. So they get polyuric, and if they lose enough, so that sugar, if the sugars are high and they just keep filtering it, wherever sugar goes, water will follow it. It loves it. So they'll just pee out huge amounts. A lot of times that's what will bring people to the doctor, especially an adult. Getting up at night. Nocturia is usually significant. If you're having to get up, remember we talked about this before, if you're having to get up 3 or 4 times a night, you remember, do you know how many times you went to the bathroom yesterday? I have no idea. How many times did you go pee at night? You remember that, right? So if you're getting up 4 or 5 times a night, you'll start complaining to somebody. And then polydipsia. What's polydipsia? Thirsty. So their water consumption goes up, and it goes up a lot. I had a mother who came in one time with a child, and she said, I knew there was something wrong, and the child had already been diagnosed with type 1. She said, I knew there was something wrong when she would go into the bathroom and stick her head, turn the faucet on full blast and stick her head under it to try to get enough water. I had a guy who came to me one time and said, I knew there was something wrong when he was a parole officer and he had a big territory that he covered, and he had this 5-gallon tank in the back of his truck, and he filled it with water. And he goes, I knew when I started going through that in a day, on a daily basis, something was wrong. So it's abnormal. It's an abnormal thirst, abnormal amount of water they're having. And they'll get into a cycle because they think, well, I'm peeing a lot because I'm drinking a lot, I'm drinking a lot because I'm peeing a lot. So it just gets into a cycle and they can't even say where it started or stopped. Triglyceride breakdown. So you got lots of fat being broken down and it goes to the liver, and one of the things the liver will do with those fatty acids is it will make triglycerides. So these folks may come in with triglycerides, sorry, of 1, 2, 3,000. One of the things you always want to do when triglycerides are high and in the face of a very high sugar is you get the diabetes under control first. Then their triglycerides usually will come down significantly. What is the enzyme that breaks down triglycerides in the blood? We talked about this when we did lipoprotein. That's why I'm saying pull out your old stuff and look through it. Lipoprotein lipase. It is an insulin-sensitive enzyme. When you don't have enough insulin around, the enzyme doesn't work very well. So those triglycerides don't get broken up. So triglycerides go up. So that's blood fats. Fatty acid oxidation in the liver. That's what produces ketones. What are the 3 ketone bodies? Acetone, acetoacetic acid, beta-hydroxybutyrate. It is the big, long-acting pool. They all have different half-lives. Beta-hydroxybutyrate is the one that takes the longest to get rid of. Okay. Acetone, acetoacetic acid, you can get rid of quickly, because you can breathe them out, but the other one takes a long time to get rid of. So if you go down this pathway, eventually what happens is you get these big organic acid production, you overwhelm the acid-base ability of the body, and you end up with a metabolic acidosis. We'll go through this again when we talk about type 1. Let's see. Protein breakdown. So muscle wasting, growth retardation. In kids, one of our goals is to restore normal growth and development. Especially kids, sometimes it's hard. This is why kids will die of type 1 because it just is abnormal. If you got somebody in diapers, how do you know how many, are they paying attention how many diapers are you going to go through? If you're in the midst of potty training, you may just not be keeping track of how much urine a child is producing. So kids will commonly, sometimes the first way they will come in the hospital with type 1 is they're comatose, would be common, and kids die every year in this state due to that not recognizing it early enough. So weight loss. Weight loss is huge. I had a young man that came that was referred to me in the diabetes clinic. He was a young guy. He was probably 22, 23 years old, worked on a dock loading, just unloading and loading, shipping. And in about a space of probably 8 to 10 weeks, he dropped 65 pounds. He said, I can't do the work anymore. So he went to the doctor when he finally just didn't have the muscle strength to take the boxes off the ship anymore, or the truck. So pretty common. Kids, you'll see it. So if type 2s, if they get insulin deficient enough, they'll come in with weight loss. Anytime I have a diabetic that is complaining of big time weight loss, I know they're insulin deficient. See, it doesn't matter. It doesn't matter if I think they're type 1 or type 2. I have to replace that insulin. Okay? So weight loss is should be a major red flag to you, even if you got an overweight adult that's coming in and saying, you know, I dropped 30 pounds in the last couple of months, and I'm not doing anything. A lot of them would be worried I've got cancer. Okay? So weight loss, huge. You can't keep your stores. You can't keep your fat intact. You can't keep your muscle intact. Blood amino acids go up. Glucose production in the liver goes up. The liver just continues to pour sugar into the system. And aggravation of hyperglycemia. Also, their appetite will go up. And they may tell you, oh, I eat a lot and I'm still losing weight. That will be the cancer story that they'll come in on. So when people are telling you I'm eating more or I'm eating the same and I'm losing weight, look at their blood sugars. Okay, so this speaks to extremes. A lot of time with type 2s, they won't have this, but they can. You've got to get blood sugars above about 300 consistently to see this. Anytime you see blood sugars that are consistently running over 250, there is significant insulin deficiency. So most of the symptoms, they'll become symptomatic when their blood sugars is sustained over 250 to 300. Okay, questions? See, based on what you know yesterday and what we talked about now, you can start to predict what the symptoms will look like. And you can start to explain why they're happening. Okay? Where to lay my thing down? Over there. Okay, so definition of diabetes. So diabetes is a group of metabolic diseases characterized by hyperglycemia. It is the foundation piece in this whole statement is hyperglycemia. Many roads to get there, but once it's there, it will tend to cause the same problems. It results, so the hyperglycemia results from a defective insulin secretion or insulin action. Maybe you can produce insulin, but the cells won't respond. That happens in type 2s. It happens probably in some type 1s, but it's not the predominant. Usually got more than that going on, or both. The chronic hyperglycemia of diabetes is associated with long-term damage. These are the things that will kill the person. Most people don't die from diabetes, they die from complications of diabetes. So various organs. The organs that are most prominent are the eyes, the kidneys, the nerves, the heart, and the blood vessels. And we'll talk about towards the end of the week what we can do to prevent those complications or slow them down. Okay. So classification of diabetes, this is probably going to undergo a change. A significant publication came out of Lancet in the last few months that looked at subcategorizing type 2. And based on what they are proposing, I think it's going to help because type 2 is really diverse. Like, well, I'll let him tell the story. Dr. Bonetta is, he claims he's type 2, but he is a variant, an aberrant variant. Most of them don't look like him. So type 1, due to beta, type 1 is, classic type 1 is autoimmune disease, autoimmune destruction of the beta cells that leads to eventually a total destruction of all beta cell activity. So these folks produce no insulin eventually. This is, even though most people know about it, it's a very small percent of the diabetic population. Probably in the range of, it says 5%, probably 2%. So very small numbers. But they require a lot of care, so they're usually known. People think about that. Sometimes people think about diabetes, that's what they think of. Small group. The type 2s are predominant. Probably 98% of people are type 2. And maybe due to a variety of reasons. This is insulin resistance coupled with some defect in insulin secretion. There are other types of diabetes, and they are usually, diabetes is secondary to these things. So there are genetic defects. We can see those in teenagers. Not very common. Genetic defects in insulin action, again, those are not very common. Now, diseases of the exocrine pancreas are more common. So if somebody's had pancreatitis, inflammation of the pancreas, and they have it recurrent, some people do because they have very high triglycerides or they had family history, and if they continue to inflame and scar down that pancreas, eventually they develop some degree of insulin deficiency. Okay? It can be due to alcoholism, it can be due to high triglycerides. Those are the more common, but there are others. Trauma. I had a cousin, or my mother had a cousin, I didn't know him, but he was in World War II, and the story is that he was on one of those islands and they were being chased by the enemy. He jumped over a ravine and landed and ruptured his pancreas and other organs, and eventually died due to that injury, but he became a diabetic from that trauma. Cancer could certainly, I took care of some patients who had pancreatic cancer, and they developed diabetes because they can no longer produce enough insulin. Cystic fibrosis, you're going to see more of them because these kids survive into adulthood. When I was in your place, it was rare that we saw any kid with CF get past 18. But now they can live normal lives. But they often develop diabetes because of the mucus production gets in is part of the disease, affects the pancreas, so very common. Endocrinopathies, the growth hormone abnormalities. People with acromegaly almost always have a degree of insulin resistance. They almost always have some degree of diabetes. Cushing syndrome will have diabetes. We'll talk about that in a couple of weeks. Hyperthyroidism, pheochromocytoma. So those are messing with those counter-regulatory hormones, which affect glucose and insulin production. Drugs or chemicals. Most of the drugs on here are usually short-term, so they may raise blood sugar, but the two that are on here, glucocorticoids always raise blood sugar, always. Most people are not on them long-term anymore, but when people are on them, they will up their blood sugar. Another would be the treatment of AIDS. So a lot of our drugs that we use for HIV will damage the pancreas and raise blood sugar. So in family medicine, I saw several HIV patients, and it was secondary to their drug use. They can't get off those drugs, so they become, usually, most of them are type 2. Genetic syndrome, very common in Down syndrome to see diabetes. And of the ones I saw in clinic, most of them had type 1. I don't know if there's a preponderance of one or the other, but most of the ones they were all type 1. Klinefelter's, Prader-Willi, Huntington's. So there's lots of primary causes of diabetes. In the end, you treat them the same. You don't really, if you can treat the underlying cause and get rid of it, great. Most of these you cannot. So we'll consider them as the same. Gestational diabetes, we're going to talk in the next module. Has its own categorization, has its own blood sugar way that we diagnose this. So I'm gonna shift it to next module. Epidemiology. Very common. It's one of the most common diseases of adulthood. So in our country, about 10% of adults have type 2, have diabetes. Okay. Very common. It's the 7th cause of death in the United States, but it's contributory to others, like it's a huge contributor to cardiovascular disease. It's also very ethnic dependent. Diabetes is not kind to minorities in this country. So you'll see that with African Americans, Native Americans, Latinos, Asians, those folks will have a higher percent or prevalence of diabetes compared to the general population or the Caucasian population. Yes?
So is that due to like incomes and diet, or is it just genetic predisposition?
Nobody knows specifically. Some thought is that those, when people come from other countries and adopt our diet, the rates of diabetes tend to go up. So some of it's thought that it invokes what's called a thrifty gene, is that if your genetic material developed in a time where there was a lot of feast and famine, that there is a thrifty gene that when there is plenty, you will store up a lot. And so that is thought to contribute to Native Americans in particular. African Americans, there's been some, when you diverge from usual dietary habits, then you see the rates of diabetes go up. But that doesn't explain all of it. There are certainly genetics. Like when you see type 1s, you rarely see type 1s in African American population or in the Asian population. But in the Scandinavian, like Finland and they have the highest of type 1s in the world. So it occurs in genetic pools as well. You'll see a predominance of one over the other. By state. Oh, well, let me do this. The other problem is type 2 is going up. Some of it's because we're getting better at diagnosing it, and we're getting better at training healthcare providers to recognize it and intervene. The other is that we know what prediabetes looks like, and we know that if we intervene with prediabetes, we can slow down the progression to diabetes. So all of that has helped. We've got better drugs, better education, so some of that has helped in terms of diagnosing earlier. But the worrisome is children are just going through the roof in terms of the number of children that are now being diagnosed with type 2. When I was in your chair, we rarely saw diabetes in people under 40s, rare. Now it's just commonplace. And never saw it in children. I would never even thought type 2 could happen in a child when I was sitting in your place. So that is going up as well. By state, this shows you in over the last 25 years how the diabetes has increased. In this state, we are, of course, one of the top 5. If you look, it's Alabama, Mississippi, Kentucky, and Oklahoma. So in all of those states, you have a predominance of ethnic groups that are at high risk. So in Alabama and Mississippi, you have the African Americans. In this state, it is thought to be due primarily to the Native American population. And it is thought that in Oklahoma, about 40% of the population is at pre-diabetes or at high risk. So if you work in Oklahoma, I just always think diabetes. And I want to teach you what it looks like coming through the door and then what you do to pick it up. Okay. All right. So the next are risk factors. Who gets diabetes? We now have a very good idea of who is at risk. These are extremely important. You must know these. They will show up again and again. So who are the risk factors? Well, it's a disease of aging. The older you get, the more likely you will get diabetes. They're even looking at a new category that is just age-related diabetes. Usually those they're less, they're usually a lower grade. They will have, their blood sugars don't get really high, but it's hard to get them to stay in the normal range. So risk factors for diabetes, and this is also for prediabetes. So over the age of 45, risk goes up. So that's when routine screening starts for everyone who hasn't been diagnosed to that point. The other is weight. So overweight or sedentary. So the weights the risk is based on BMI. So a BMI of 25 or greater. That takes in a lot of the population. For Asians, it's a little bit different. It's a BMI of 23 or greater because they tend to carry visceral fat differently than other ethnic groups. If you have a family history, here family history only counts in first-degree relatives. So your mother, your dad, your siblings. Here's one thing I found though when I was working with the Harold Ham group is we did large-scale screenings throughout the state of 18 to 39-year-olds. We were looking to see if we could, to try to figure out what was the risk in that population of cardiovascular disease and diabetes, and then to do education. We also were trying to address a group that usually doesn't have great insurance. It doesn't go to the doctor very often because they're not very, usually not very sick. Here's what I found here, that in talking to them, their parents weren't old enough. Their parents were like 40, if I was talking to 18-year-olds. So what I started to do is asking about grandparents, especially if they were an ethnic group at risk. So I'm not saying that that is a good thing to do, but I found over time it was helpful, is to find out what are your grandparents, what about them? So it goes against that norm. It's just an N of 1, but I found that in very younger people at risk, I would tend to ask about the grandparents because the parents' generation hadn't been diagnosed yet. Let's see. Members of high ethnic population, you must know these. So African Americans, Asians, Native Americans, Pacific Islanders, we don't see a lot in this, this state, but you will in other parts of the country, and Hispanics. If they walk in and they're overweight, I'm already thinking I need to get you screened. If a woman has a history of gestational diabetes, women who have gestational diabetes first diagnosed during pregnancy, almost all go on to develop type 2. Within 15 years, 75% of them will be type 2. I don't care if they're this big around. Okay. In fact, most of the gestationals I saw were this big around. Because a lot of them were preemies. So I think just didn't get enough insulin, or their pancreatic development wasn't normal. And so you stress them, and they come up with diabetes. Okay, here becomes those peaks. Remember I talked about those peaks of the iceberg? Hypertension. 60% of people with diabetes have hypertension. It is a concomitant disease, comorbid disease. Diabetes almost always has hypertension. Look at your hypertensive patients because they tend to have insulin resistance as a root cause. Lipid disorders. They have low HDL, high total cholesterol, or they have high triglycerides. Look for those patterns. And they're hypertensive, and they've got a big middle. Now you've got metabolic syndrome. They've had an A1C done on a previous test that was 5.7, was greater than 5.7 or greater. Know that number. It's one of the first diagnostic criteria for pre-diabetes. Okay. So diabetes we don't diagnose until the A1C is 6.5%. So there's a group in there. That group is important because with pre-diabetes, about 20% will move to diabetes every year. Okay, so they're a big group to identify. If you're physically inactive, we are made to work. We are replete with muscle. We were made to be out there doing things. If you're sitting all the time, you're metabolically inert. Eventually, you can become insulin insensitive. Women with polycystic ovarian syndrome. Well, I don't know if this comes up next. If it fits anywhere, it would fit in OB. Okay. So these women tend to have. They usually come to the doctor because they can't get pregnant. The way they look is usually they have huge middles, they're apples. They'll usually have facial hair, so they'll have an oily skin, so they have very high circulating androgens. They are also very insulin resistant. They're high risk for cardiovascular disease at a young age, and they usually have diabetes or impaired glucose tolerance by the time you see them. So that's why that group, they're a unique group, but pay attention to them if they come across in your primary care. Other conditions associated with insulin resistance, severe obesity would of course be one. Another is acanthosis nigricans. Have y'all talked about that yet? Okay, we will in derm. It usually reflects an insulin receptor abnormality, and they develop these velvet-like skin, especially in deep folds. So in the neck is a very common place. The one thing they'll tell you is that, you know, when I take a bath and I dry off, my towel turns brown because they're rubbing that skin off. But it is a change in the skin that's reflecting an abnormality. So that's called acanthosis nigricans. Whenever you see it, you got to think diabetes. Very common to see it in kids who have that abnormality. Look for it and then check their blood sugars. Or if they have a history of cardiovascular disease. Often type 2s are first diagnosed when they have a cardiovascular event. It's very high. It's like, I'm making this up, but just to give you an idea, it's like 60 to 70% of people first MI, they have blood sugar abnormalities. So very high. Think cardiovascular disease, think there's usually some type of disturbance in their glucose metabolism. Okay? Know those. Know those risk factors. Okay. So that's the face of diabetes. Mostly ethnic groups. I look for them whenever they come in and they are overweight, I am thinking diabetes. These kids are from a Native American camp that we ran through the Harold Ham. And these were all kids from different tribes in Oklahoma that were at risk or had diabetes, and they came for a week-long camp. They were a lot of fun. Oh. Some of the tribes, the Pima probably are the highest, but over 50% of that tribe will develop type 2. Very high with the different tribes. So Native Americans carry a disproportionate risk. Okay, so type 2. On page 6. Type 2 has a predominance of genetics. So it is very much a disease that you inherit. There are environmental factors that usually will make it come out either early or late. In the past, you could have inherited it and not been diagnosed until you were 60 or 70. Nowadays, because we're heavier, we don't move as much, these people are diagnosed as kids or in early adulthood. If you have a parent who has type 2 diabetes, your risk of developing type 2 is 50%. If both of your parents have type 2, your risk is 80%. Okay? But there are things that you can do to delay the onset. You probably can't avoid it, but you can delay it. Okay. So type 2 is very heterogeneous. It just doesn't look the same across the spectrum. And that's why people are looking at developing better descriptors, because these people act a little bit differently. The triumvirate of organ impairment up there involving insulin resistance is the liver and the muscle, meaning they're very resistant to when insulin is present. They'll interact with it to some degree, but not to the full extent that it would if the resistance wasn't there. And there's impaired insulin secretion by the pancreas. That is foundational of our understanding right now. So resistance, liver, peripheral tissue, insulin, and the impairment of insulin secretion. In the liver, the resistance is manifested by glucose overproduction. So it will continue to put glucose into the system even in the presence of insulin. So glucose output is elevated. It's worse overnight. So when you're sleeping, the liver's keeping your blood sugar normal. Liver output at night goes way up. You're not eating, but the sugar is there. That's why people can wake up with very high blood sugars in the morning and they haven't eaten all night. In the muscle, insulin resistance is manifest by impaired glucose uptake. So it won't take up the glucose when the sugar is present. I'm sorry, when insulin is present. Okay, so what happens over time is that it's thought that resistance probably is the first problem in the liver or in the periphery. That is what starts the process for whatever reason. You see in that picture below is that you have a time of impaired glucose tolerance. Here is diagnosis. Right here. Okay. So you see that if you go back 8 to 12 years, there is already impaired glucose tolerance is showing up. Now, you don't catch it because they're not symptomatic, and you would only catch it if you were looking for it shortly after they ate. So most of the time, what do? You tell people if they're going to have lab, what do? Tell them to come in fasting. You give these people long enough, they can get their blood sugars down to normal. Okay? But after a meal, they have high rises, and it takes them a long time to come back to normal, but given enough time, and you told them to fast 8 to 12 hours, blood sugar will look normal. That's why we don't pick it up, usually with a fasting. Okay? So that goes on for a period of time. Then it starts getting worse, and it really shows up after they eat. So here you might get a random blood sugar, and it's a 190. Do you have diabetes? Nope. So that is abnormal. I've already told you that usually it doesn't go above 140. We don't have any diagnostic criteria for randoms that are under 200. But it's already telling you that there is an impairment in their ability to keep blood sugar down after a large meal. When they come in for diagnosis, it's usually because you've run lab and they're fasting and they're slightly elevated, or they've come in symptomatic. Okay. So you see that they already have about 8 to 12 years of disease process already going. And this is debated. Some people say 10, some say 5 to 9. The problem is that damage has occurred to organs, and so complications could already be present when they show up and are diagnosed. So keep in mind that the process has been going on a long time before they see you. So insulin resistance has been thought of as a decrease in the either receptor number, the inability to move those GLUT or transport molecules to the cell surface and get them to bring glucose in. For whatever reason, some define it as signaling problems. Insulin sits on the receptor, but then everything that the cell's supposed to do with insulin shows up doesn't take place. So resistance can take in lots of factors. It doesn't have just one look. This shows you a normal cell with 20,000 receptor sites. This one has 5,000. Okay, you just can't get as much sugar in. Okay, this is an important slide. Let's walk through this. So you see in the green, normal, you see insulin resistance is normal. Blood sugar is in normal range, and insulin production is normal. When you move into that pre-diabetes, what do you see in those lines? Resistance goes up, so that's those peripheral tissues and the liver. If you've got non-alcoholic fatty liver disease, insulin resistance is very high in that disease. What about blood sugar? What happens? Stays pretty normal. At the expense of what? What is keeping it normal? Insulin. So the beta cell, because we have said that in response to elevated blood sugars, what will the beta cell do? Put out more insulin. So if there's resistance out here, insulin's going out here, but the sugars are not going down, the beta cell just works harder. It just puts out more insulin. So it could be that if you tested somebody in this, when they're in that range, their blood sugars are going to look pretty normal, but if you tested their insulin or their C-peptide, it would be high. You hit a point. Okay, so there comes a point where the beta cell just will no longer respond to being beaten over the head and to produce insulin, and nothing happens. Okay. So we call that beta cell dysfunction. It takes about 15 years, well, probably less than 15 years, but it takes a number of years of that continuing to happen before the beta cell will no longer respond. So when you cross that red line, what do you see? What happens? Insulin production starts to go down. What happens to resistance? Stays the same. What happens to blood sugar? Goes up. That's usually where you are diagnosing people. Okay? So we can, from the onset of dysfunction to that end point there at the end of the red is about 15 years. Eventually you get to the point where beta cell function will still limp along, and they'll never not make insulin, but the way they make it is dysfunctional. Dysfunction in that a high sugar is no longer responded to with enough insulin to bring it to normal. That is type 2 diabetes. So these people are different. They usually don't get big breakdowns in tissue. They may lose weight, but we never see the carnage that we see out of type 1. Because they can produce enough insulin to keep things kind of arrested. Okay? But they suffer nonetheless in terms of damage to other organs because of high blood sugar. So we can bring insulin resistance down. If we can get you to lose weight and move, that is two of the biggest things you can do. So if you can lower resistance, it is hard to lower resistance with drugs. We thought we had a class of drugs that did that, but man, they have problems and they're not used very much anymore. So resistance really goes at lifestyle, weight reduction, what food choice, moving around. And blood sugar, we can control blood sugar, but it will take an army attacking at different points to bring blood sugar down. And we can replace the insulin eventually. Study this. This is an important concept. It's important to have an idea of where people are when you see them. This is another that goes through natural history. It's just another way of looking at it. Puts a few more pieces of information in here. So impaired glucose tolerance usually doesn't show up unless you do special tests. You often will not see it on a fasting blood sugar. You might, but most of the time it occurs postprandially. So the problem is in a postprandial. These people lose that first phase of insulin release. And so what does that mean? If you lose first phase, what's its job? Tell the liver to stop putting glucose out. Type 2s lose first phase. Their second phase is, in the beginning, is high and sustained for a long period of time, and eventually it will go down because it will bring blood sugars back to normal. But it really has to work overtime to do it. So impaired glucose tolerance shows up postprandial. So the most of the problem early on is postprandial, after you eat. And it will very much reflect what the person ate. If they nibble on carrots and celery, their blood sugar can go very high. But if they eat that piece of pecan pie, they will zoom up to 300, 400, 500. Undiagnosed diabetes, they put there in the middle. And then known diabetes, people are usually symptomatic, and you see the same types of things. Insulin resistance is high. The symptoms are coming because the insulin can no longer regulate fuel, and so that's when symptoms start showing up. So if insulin can't regulate the fuel usage or storage, what do the kidneys do? Okay, what does glucose do? Where's glucose in these folks? It's very high. So how are you going to deal with it? What happens with the kidneys? They excrete it. Okay. What happens to let's see, what other symptoms do people come in? So the thirst. So the osmolality is going up. The kidneys are going up. They're fatigued. Why are they fatigued? They don't get energy into the cell to the extent that they need it. So they'll just tell you, I'm tired. I feel like I'm dragging around a huge weight all the time. Okay? The other thing they're going to tell you is that I'm hungry. You're sitting there looking at a 300-pound person, and they're telling you, I'm hungry. I cannot get enough to eat. Why is that? I take them seriously. Why is that?
Because they're not getting fuel.
They can't get the fuel into the cells. So their brain constantly tells them, I'm hungry. What I find usually when people are at that point and I put them on insulin, I usually, just in watching over the years, is that people probably up their caloric intake about 30 or 40% over what they need. Do you have any, because when I put them on insulin, they immediately gain like 15 pounds because they can hang on to everything they're eating. So usually you have to readjust and teach them how to eat again. But they'll overeat to compensate for that sense of being hungry. So when they tell you they're hungry, they are. I've had primary care people, I've watched them laugh at them in their face. I'm telling you, they're hungry. Okay? Because they cannot get the fuel in. They are in a fuel dysregulation. Fasting blood sugar goes up, and that's usually where we're finding most of the time, or in postprandial goes up. Look at the bottom though. Microvascular and macrovascular. Macrovascular complications are what it does with the heart. Okay? Look at where the threshold is. It's pretty low. There is no bottom threshold for macrovascular disease. Probably starts at an A1C of about 5 or 5.5%, which most of us live with, and then it goes up from there. Okay? We can never get it back to normal. Microvascular has a higher threshold, about 8% A1C. So that one, usually we can intervene and keep them from developing those, or we can delay their onset. But you see those complications usually are already started by the time you diagnose them. That's why early detection, early education, early treatment can prevent them from moving on. So we can actually when we are in this range, we can move people back here. Now, they're not normal because we have treated them to normal levels, but we can move people back. That's the good news, and we'll talk about that this afternoon. Is prediabetes, we know enough now that we can move them back or arrest what is going on. That's big. If you've done that, you've saved somebody a lot of grief. Okay, here's that first and second phase again. So what do you see with early type 2 on that page? Lost first phase, so important. Okay. And look at you don't get at, this one is elevated and it's continuing on. So it can stay elevated for hours. But usually in those people, they can get their fastings back to normal range. What do you see in late type 2? That second phase is much lower. They just cannot put out enough insulin. They will always put out insulin. A type 1, this would be flat. There would be no insulin on there. Okay. Important concept. So we can use drugs to help with this. So we use metformin to suppress that glucose amount coming out of the liver. Okay. Several years ago, a man by the name of Ralph DeFranzo, he's fairly well known in diabetes circles. He runs the big diabetes care center in Texas, down by Austin. And he came up with this concept of the ominous octet. And so he put together, and he won a big award for this, in terms of all the things that are playing in and are increasing blood sugar. So as the information became more available, it's just a very complex problem is what to take away from this. So if you look on the top of page 9, so the triumvirate, we talked about beta cell dysfunction, the resistance in muscle and liver, those are the 3 big organs. But we've also got lots of resistance coming from adipose tissue. Remember we talked about it being a metabolically active organ. It's not just fat that sits there. But it also is adding to the problem. Another big thing is we get a decreased incretin effect. So what did incretins do? What was their job? They're produced by what cells? L cells, where? Intestines, okay. And they produce, what are the incretins? Name one of them. GLP-1, GIP, and GLP-2. So they are released in response to what? Food coming into the gut. And they send their signal to what? 2 places. The pancreas, and it tells the pancreas what? Food is coming, and it, based on the blood sugar amount, it will stimulate the beta cell to produce more insulin. And the other place it goes is the brain. It tells the brain what? You've had enough. Satiety. Okay. Increased glucagon. Glucagon is a problem in type 2s. You keep putting in out. What's glucagon's job? What its big target is what? Liver. And it tells the liver to do what? Release or break down glycogen and release it as glucose. Okay. So if glucagon is unrestrained, it just keeps the problem going. There's not enough insulin, the signaling to the liver is gone, so the liver is under the authority of glucagon. And so that's what it does, because it's lost its influence of insulin to a great extent. Renal glucose reabsorption to maintain elevated plasma. You get some, so you're getting reabsorption of glucose, but it is a limited system. It is a saturable system. So eventually that sugar will end up in the urine. And then the central nervous system is resistant to the anoretic effects of insulin. So it's like, I'm not getting enough. This is where that hunger is coming from, is that the brain is now a player and saying, I don't have enough. So it makes them hungry. So appetite dysregulation, weight gain, insulin resistance in the muscle and the liver. So multiple organs are playing in here. I'm telling you, the priority in the body is fuel. If it doesn't have that, it dies. So there's multiple systems, hormones, organs, neuropeptides that are playing into this dysregulation. We only know about the tip of the iceberg, but we know enough to make a difference. Okay. So diagnosis, so by the time you diagnose people, they usually have lost functionality of half their beta cells. Now you're given a lot, you're given 1 million when you're born, okay? So that's why they still function, they may not even be symptomatic, but from the time when they are diagnosed, they have lost about 50%. It's enough to cause trouble. This just shows you different time frames. Okay. So clinical presentation on top of page 10. So what are they going to look like? Most of them are going to be asymptomatic. That's why having an idea of who's at risk, when they walk in the door, you ought to be able to identify them. It doesn't matter that they're 25 years old. It doesn't matter if they're 18 years old. Check their blood sugar. You will do them a favor. So we'll talk about this afternoon in ClinMed, what kinds of questions you ask. If you ask and get family history of diabetes, they are overweight, and they are a high-risk ethnic group, check their blood sugar. So a lot of people are asymptomatic, so provider awareness is important. You now know, so you can be part of the solution. There are standards out there. I'll weave those in everything I talk about. Part of the standards is recognizing risk and screening appropriately. Patient request. It is not unusual for patients to come in and say, my mom has diabetes and something happens. Maybe she has an amputation. So the daughter or the son comes in and go, I want to be tested. That is appropriate. Sometimes just in a community of patients. I noticed when I moved in and was working more with African Americans, diabetes is so commonplace in their community that they don't even think about it. When I first started talking to them, it was like, well, no big deal, everybody gets it. Native Americans, I've seen the same thing. It's just part of what happens as you get older. So sometimes you have to shake them out of that complacency, and it's like, no, this is important. But patient request, it is very likely it will come. Or a patient will come in and go, my mom has diabetes, and now I am having these symptoms, and I'm worried it's diabetes. I saw that quite a bit. Concurrent illness or stress. When you stress the body, stress hormones go up. So those counter-regulatory hormones go up. You're in an automobile accident, we put you in the hospital, your stress hormones are high. You have an MI, stress hormones go up, they're high. So what do? They counteract insulin's effect. What happens to blood sugar? All those counter-regulatory hormones are going to raise your blood sugar. So when people are stressed, traumatized, psychological stress will do it as well. Their blood sugars will go up. So sometimes they will reveal or unveil a potential diabetes risk that normally without stress is not there. We see it in gestational. Once you deliver the baby, their blood sugars go back to normal. But we know the risk is out there. So sometimes during extreme stress, we treat what is going on, we wait to see what they're like when they're normal. But those folks always need to be at higher risk for being screened like every year. Like people, gestational diabetics, once they've had gestational diabetes, they ought to be screened every year. Okay, page 11. So they present with signs and symptoms of hyperglycemia. So what would that look like? Looks something like this. A lot of your people would, fatigue, they may not complain about fatigue. Sometimes it's so insidious that it just becomes part of life. Or, I'm older, so I'm tired. So that may not be significant enough for them to complain about, or it might. Always thirsty, urinating often, that needs to be worked up and looked at, because those are very common, and they're usually extreme. Change in vision. So sugar can move anywhere because it's little, and water likes it. So any place there's water, it can move into. So it'll move into the lens of the eye. The lens cannot get rid of it. And so what happens is the sugar's there, so what happens to water content in the lens? It's bigger and bigger. Eventually the lens can get rid of it, but blurry vision is a common presenting symptom because they can no longer accommodate. So their ability to read a newspaper or print material, or their tablet now, we used to say newspaper, I guess. They can't read things that are very close to them, that they could before. Or another way they'll do it is they'll go for a eye checkup. And so often the ophthalmologist, optometrist will always ask, are you diabetic? What's your blood sugar? Because it's very common for people to change their prescription because they can't see, when it's really the lens has been affected from hyperglycemia. We talked about the always hungry, can't get full. So another way they may tell you is that I eat a meal, but I'm hungry in an hour or two. You know, I just ate a Big Mac, but I want to eat again. So it's usually a big meal. They can get satisfied, but they come back and they want to eat again soon after. Weight loss, always think blood sugar. Sexual problems. So if you're looking at ED, then usually that's one of the things we're going to be looking at because it affects nerves and vasculature. Wounds that won't heal. A lot of people know this. Something happens and it just doesn't heal for a long time. That should raise awareness. Women who have frequent vaginal infections, if they have more than one or two in a 6-month period, you ought to be looking for what's their sugar. Numbness or tingling in hands and feet. That's a hard one to, lots of things will cause that, but thinking about blood sugar is part of it. Usually patients will come in with a cluster of symptoms, not just one. The biggest thing you can do is have a high awareness for it, particularly in the area where you live, depending on where you end up practicing. Okay, so why do we worry about this? So the last page is the reason why we worry about this is because glucose is really hard on the body. Glucose will attach to any protein. It has no discriminating behavior. So it will attach to protein everywhere. And when it does, it glycates that protein, and that protein never works as well as it should. So that happens in the basement membranes of the kidney. It happens in the vasculature. It happens in the eyeballs. It happens in our nerves. We demyelinate over time. So the complications of diabetes are what compromises quality of life and kills people. So if we can restore blood sugar to normal or near normal, we can prevent or delay these complications. That's huge. We'll talk about the landmark study that showed that probably later today. So the big one are the eye complications. The #1 cause of new blindness in the United States in adults is diabetes. Nephropathy. The two big causes of the reason why people are on dialysis is usually hypertensive disease and diabetes. Neuropathy. Very common. It is one of the #1 causes of non-traumatic amputations in the United States is due to diabetic neuropathy. Vascular disease. I told you 75 to 80% of people with type 2 will develop cardiovascular disease. It's the #1 cause of mortality in type 2. Okay? So lots of reasons to pay attention to people's glycemic status. Now more than ever, because it's just very, very common. But there's good news. There's good news. We can do a lot to treat and help people live very good and long lives. The people, so insulin was found in, was discovered by Banting and Best, Canadians, in 1921. Prior to that time, your life expectancy, if you were diagnosed with type 1, was 18 months. So the American Diabetes Association gives awards every year, they're Banting Awards, to people who are still living, and there are still people out of that 1920s group that are alive. And they put their picture out. So there are people that live with type 1 50 and 60 years. And I'm telling you that the insulin that they first produced was just about as crude as you could get. And they're still alive. So there's great hope, but you are part of it by helping patients by, first of all, diagnosing it, and then educating them, treating them well, and getting them into proper referrals. All right. Yes. Okay, so we'll come back and we'll talk about how do you clinically work somebody up that's coming into your practice or you're seeing at 1 o'clock, and then we'll start talking about drugs after that. All right.